Hi there, everybody. We are welcoming a new discussion on kidney disorders and the documentation opportunities present in the documentation of kidney disorders to really reflect the severity of illness and the resources needed to take care of these patients. So thank you for coming to this part of the session. As with all my presentations, there's a disclaimer statement. Every effort has been taken by the author of this presentation to ensure that the information shared was as accurate and as current as possible at the time it was developed and presented. The primary intent of this presentation is to be informational only and to share it in a manner that is more relatable and understandable to those in healthcare with various backgrounds and levels of experience. The information that is shared is truly only intended and just that to be informational and not to take place over any precedence over any state, local, and or federal organizational policies and or procedures. Many of the items on the slide you're already aware of, but just be mindful when we use arrows pointing down or arrows pointing up in terms of urinary output or creatinine or other abbreviations that we use commonly. Just be mindful they do not transfer to coded language. A coder is not able to assign a code to that. Also, and again, you already know this, according to the Kidney Disease Improving Global Outcomes organization, AKI is a condition with an abrupt decrease in kidney function that is inclusive of a wide variety of causes. Also, according to their 2023 update, acute kidney diseases and disorders, AKD, include abnormalities of kidney function and structure present for less than 3 months. Chronic kidney disease is an abnormality of the kidney structure or function that are present for greater than 3 months with the consequent implications for health. It is critical to be as specific as possible for us to be able to tell the story, read the story that you, the attending provider, have written that paints a picture of the severity of illness and the risk of mortality of the patient condition. So in order for us to be able to capture that in codes, we need to be able to have the provider documentation of the attending provider document the severity of illness and risk of mortality of the condition that the patient is experiencing. Hi, everybody. So just to share with you, and many of you know this already, but this chart here will speak to the AKI stages that are one of these 3 levels of, of stages. The criteria speaks to the severity of AKI. So that is what they're looking at, stage 1, 2, or 3. And again, this speaks to the severity. When we're speaking about chronic kidney disease, it is very critical to specify the stage. The diagnosis of CKD supports a higher DRG assignment, which affects the relative weight assigned to it. And again, just to reiterate, it is the relative weight times the hospital base rate that will determine the hospital payment. In addition, the increased severity of illness and risk of mortality that is associated with a patient that is sicker and requires more resources in terms of hospital care, in terms of provider care. It really adds to the scoring of all the leading to more appropriate reimbursement calculation to the facility. So again, this all plays in together. It is the documentation that leads to the more appropriate code assignment because it is reflective of the severity of illness and the risk of mortality scoring that all lead to a more appropriate reimbursement calculation to the facility to cover the resources that were required to take care of this patient. Document the reason or cause of the AKI, such as acute tubular necrosis due to rhabdo. The approximate incidence of AKI in rhabdo is about 13 to 50%, depending on your population. It is always critical to coding to the highest specificity that the cause and effect relationship between a disease and the other condition when it exists. This is critical. These patients are often sicker and require a higher intensity of care, more resources to care for them. They will often have an extended length of stay, require more nursing monitoring and care, more evaluation, more workup, so that needs to be reflected. And your thought process, the attending provider's thought process, needs to be well documented. It is again linking in the documentation any other related conditions caused or related to the AKI, such as tubular necrosis, cortical necrosis, vasculitis, interstitial nephritis, all these conditions. If a patient is admitted and cared for with a coexisting condition of both acute and chronic kidney failure, then they both should be documented because, again, it reflects a higher intensity of care and more resources to care for the patient. It speaks to their severity of illness and paints a picture of how sick the patient is and the medical necessity to keep them in an inpatient bed in an acute care facility. Here then is an example of how further clarification of the CKD stage uh, allowed for a more accurate picture of the severity of illness and risk of mortality of the patient condition that this patient is experiencing. Therefore, as we can see in example 1, where the patient had a partial small bowel obstruction, coronary artery disease, they're type 1 diabetic with chronic kidney failure, documented with a relative weight of 0.6372, severity of illness of 2, and a risk of mortality of 1, as compared to when further clarification of the chronic kidney disease stage was clarified beyond that of chronic kidney failure to that of chronic kidney disease stage 4. The same partial small bowel obstruction, CAD, and type 1 diabetic. The relative weight increased to 1.6564. Again, this more than doubles the payment to the hospital because this patient has a greater severity of illness, a higher risk of mortality. This patient is much, much sicker, requiring a greater intensity of resources to care for them. And so now we are more accurately able to capture and be reimbursed for the cost in terms of the resources to care for this patient. Again, so it is critical. The attending provider documentation is absolutely essential that we are able to tell the patient story, read the patient story in that attending provider's documentation that is inclusive of all the conditions that the patient is being treated, evaluated, worked up for, that paint the picture of the actual severity of illness, how sick this patient is, and the risk of mortality that is associated with the diagnoses, and also the associated procedures. All the procedures on this account allow the appropriate assignment of the DRG that that has the unique relative weight assigned to it that reflects the resources that the hospital expended to care for this patient. It is critical to document the provider thought process in terms of monitoring and treatment plan of why this patient is receiving care in an acute care facility. It adds to help justify the medical necessity to keep the patient in an inpatient bed in the acute care hospital, because again, if there's no medical necessity, there's no payment. Quality documentation supports optimal coding and the ability to capture the intensity of resources that this patient required. Please, and I state please, do not use the term urosepsis. I cannot tell you how many times I've seen this term used in a chart. The reason why it should not be used is because, for one thing, you'll be sent a clarifying query because are you saying that the patient has a UTI or are you really saying that they have sepsis due to a UTI? The attending provider will be sent a clarification query as to which diagnosis they intend to be documenting. Urosepsis is not a codable term. Sepsis due to UTI is more resource intensive than treating a patient for a simple UTI. The documentation needs to be reflective of the actual severity of illness of the patient's condition. So urosepsis is not indicative of a diagnosis that is codable to be able to reflect the intensity of resources. So please, if you mean to say sepsis due to a UTI, please document that. Again, no money, no mission. If we want to have a hospital to take care of patients at, to carry out the mission of caring for those in need, we need to work collaboratively and really understand where each other comes from and how we all play a part. This is just a list of resources that I use to really help with the development of this presentation. This is the second page of resources and references that I use, so I hope you find these helpful. Again, I thank you for joining the conversation as we further explore the documentation opportunities that really reflect the intensity of care and the severity of illness and the resources needed by the hospital to care for these patients so that we can keep the doors of the hospital open because we all are part of a team that share the common goal of providing care to patients in need.